Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY5 resident at the University of Pittsburgh, and today we will be reviewing oropharyngeal cancer as part of our head and neck cancer series. If you haven't already, I would definitely encourage you to check out some of the earlier videos that I released as part of the head and neck cancer playlist. So there's two videos going over anatomy, one about the disease sites of the head and neck, and then the second is about the lymph node regions and their anatomy and which specific lymph node regions we tend to cover for particular disease sites. And then there's another video reviewing general principles of head and neck cancer. And in that lecture, we go over the data for the different dose fractionation regimens that we use for head and neck cancer, as well as the studies kind of guiding our use of concurrent chemotherapy, both in the definitive and in the post-operative setting. So those videos I think are very important to set the stage for all of our kind of sub-site specific lectures. And then one by one, I'm trying to get through the different subsites within head and neck to try and highlight the nuances and details and evidence that's kind of unique to that subsite. In our last video, we talked about oral cavity cancers, which are very common for head and neck, but they're probably the second most common site of head and neck cancers. The oropharynx is actually the most common site of head and neck cancers. So recall that the oropharynx has 4 different subsites. So these are the base of tongue, the palatine tonsil, the soft palate, and the posterior pharyngeal wall. So kind of everything that's behind the hard palate and behind the circumvallate papillae that kind of are the boundary between the anterior 2/3 of our tongue and the posterior 1/3 of our tongue. So base of tongue, palatine tonsil, soft palate, and posterior pharyngeal wall, 4 different subsites. And this is the most common site of head and neck cancers, accounting for slightly more than 30% of head and neck malignancies. Now, over 90% of oropharyngeal cancers are squamous cell carcinomas, and they do tend to be predominantly in males with a 4-to-1 male to female ratio. In terms of their biology, there are 2 different biologies that make up oropharyngeal cancers. There's HPV positive and HPV negative. There's a surrogate marker for HPV, which is P16, and P16 positive or HPV positive are kind of the same thing, cancers associated with HPV infection, and P16 negative are also HPV negative, and these cancers tend to be associated more with tobacco and alcohol versus HPV infection. Now, any cancer can be HPV mediated, right? There can be cancers in other subsites of the head and neck that are HPV mediated. Anal cancer, almost 80 to 90% of the time is actually HPV mediated. However, in oropharyngeal cancer in particular, HPV positivity has been associated with a much better prognosis compared to HPV negative oropharyngeal cancer. So much so that in 2017, when the AJCC 8th edition staging came out, HPV positive oropharyngeal cancer specifically was classified as an entirely different disease compared to HPV negative oropharyngeal cancer. So that means that HPV positive oropharyngeal cancer has its own staging system. And as we will see, the staging system for HPV positive oropharyngeal cancer groups even the most aggressive of cancers that would be considered a stage 4 if they were HPV negative or in the old staging system. In the new staging system, these HPV positive cancers are having much more favorable stage groups. So something that would otherwise be a stage 4, if it's an HPV positive oropharyngeal cancer, it's being staged as a stage 2 or a stage 3 because these are associated with such an improved prognosis compared to HPV negative counterparts. And again, this kind of phenomenon really applies only for oropharyngeal cancers. Now, there are ongoing efforts based on the improved prognosis in HPV positive patients to try and de-escalate therapy for these HPV positive patients, and studies looking at de-escalation in this population will be kind of a huge focus of our evidence portion of this talk. But I did just want to kind of provide that background because I think it's important to realize how important HPV status is for oropharyngeal cancers, and to realize that HPV positive or P16 positive tumors really have a significantly improved prognosis compared to HPV negative. And a huge area of research in the head and neck cancer field is to try and figure out how we can take advantage of that to try and de-escalate therapy for these HPV positive oropharyngeal cancer patients. So my objectives then are to cover oropharyngeal cancer as comprehensively as possible, starting with some basic background, getting into the staging, treatment paradigm, and then evidence base. Presentation and workup tend to be similar compared to a lot of the other head and neck subsites, but let's take a closer look. Most commonly, oropharyngeal cancers will present with a painless neck mask from enlarged cervical lymphadenopathy. Oftentimes, men will be shaving and notice a bump on their neck, and oftentimes that's how they present. Other symptoms that can be related to the primary tumor itself, things like dysphagia, odynophagia. They may have otalgia, which is referred pain from a branch of the hypoglossal nerve or cranial nerve 9. It's called the tympanic nerve of Jacobson. It's a branch of cranial nerve 9, and it actually innervates the middle ear and the eustachian tube, so that can lead to some inner ear pain. Oral tongue fixation, if that happens, actually suggests quite an aggressive primary with deep muscle involvement. Trismus suggests something like medial pterygoid invasion that's actually affecting jaw function. So depending on how advanced the presentation is, how much it interferes with chewing and swallowing for patients, that can also impact their overall kind of status. It can lead to weight loss if they're not able to eat and drink properly. So it is really important to assess kind of their performance status, if they've had weight loss as well, and their overall nutritional status. We mentioned earlier that HPV positive and negative tumors really exhibit different tumor biology and very different behavior, and so it makes sense that their risk factors are very different as well. So patients with HPV positive oropharyngeal cancer tend to be younger, they tend to be non-smokers or have less of a smoking history. They tend to be Caucasian, they may engage in high-risk sexual behavior, thus explaining the HPV infection. More likely, their tumors are going to involve the tonsil and the base of tongue. They're more likely to be non-keratinizing or basaloid. They have P16 upregulated, which, as we discussed, is a surrogate for HPV positivity, and they often tend to be poorly differentiated. HPV-negative cancers tend to occur in older patients. They tend to be associated with heavy smoking or drinking history, non-Caucasian race, not necessarily related to sexual behavior, no tissue preference. They can be keratinizing. They often have more aggressive mutations such as P53 mutation or EGFR amplification. Workup is pretty standard for head and neck cancers, and it's not very groundbreaking for oropharyngeal cancer compared to the others. Presenting symptoms are very important to inquire about because we can get a sense of kind of the invasiveness of the cancer based on their symptoms, and also if they're having any cranial nerve involvement. We always want to assess if they've had significant weight loss, inquire about their nutritional status, and also inquire about risk factors, especially smoking, because we know that patients that are non-smokers or have light smoking history are more likely to have HPV-positive cancers, whereas patients with a very heavy smoking history are more likely to be HPV-negative. On exam, you definitely want to kind of visually inspect, do a cervical exam to assess for cervical lymphadenopathy. Definitely palpate the base of tongue, take a look at their teeth, do a neurological exam. Also perform flexible laryngoscopy to take a closer look at the oropharynx, examine the tonsils, base of tongue, posterior pharyngeal wall, and all of that. In terms of labs, CBC and CMP are pretty basic. It's really important to assess their renal function, especially if we think they might be requiring concurrent cisplatin with their radiation. So remember, cisplatin affects the kidneys, and if patients don't have adequate renal function, then they are not a candidate for cisplatin. In terms of imaging, a CT neck with contrast is kind of the gold standard to evaluate the primary. It also helps us to look at the lymph nodes. PET CT is really, really helpful for staging as well, and it's really nice to help evaluate regional lymphadenopathy, also rule out distant metastasis. And if there's any concern for perineural invasion or base of skull invasion, we definitely want to consider obtaining a contrast-enhanced MRI as well. In terms of pathology, an FNA biopsy of any suspicious lymph nodes is typically adequate for even HPV testing. So that is acceptable for initial diagnosis, and we always want to perform HPV testing. Now, HPV testing is really recommended only for oropharyngeal head and neck squamous cell cancers. Sometimes we will see it for other subsites in the head and neck as well, but it's really only in the oropharynx that HPV status affects the staging and might affect their treatment if they are eligible for clinical trials. And then the ENT will often perform a detailed exam under anesthesia, and they will perform a tonsillectomy or a base of tongue biopsy as a confirmatory diagnosis to biopsy the primary, essentially. We talked extensively about the different referrals that our patients should be getting in the oral cavity lecture, but just to review, all head and neck cancer patients, we want to refer them to dentistry to evaluate for any teeth that might need to be pulled out. We also want the dentist to prescribe a fluoride toothpaste because we know that radiation impacts salivary gland function and causes xerostomia, which can increase your risk of cavities. So the dentist prescribes a fluoride toothpaste for patients to use to protect them from getting cavities. We want them to have speech and swallow evaluation formally, and if they're unable to eat or drink up front, a feeding tube is indicated to supplement their nutrition during radiotherapy. And I always counsel any head and neck cancer patients that if they're going to have greater than 10% weight loss during radiation, then partway through treatment, we might consider inserting a feeding tube at that point if they're just not able to maintain their weight. Nutritionist referral, as well as an audiogram. If patients have hearing issues up front, that's another thing that might preclude them from cisplatin-based chemoradiation. So now we get into the good stuff, and this is HPV-associated carcinogenesis, which is kind of unique to oropharyngeal cancer. Now, HPV infection is not unique to oropharyngeal cancer, right? HPV can be associated with many different cancers, and many head and neck cancers can have P16 positivity, HPV infection, even anal cancers have HPV infection. The thing that's unique about oropharyngeal cancer is that HPV infection has been shown to be associated with a significantly improved prognosis compared to HPV-negative tumors. So how does HPV actually cause cancer? So HPV encodes some viral oncogene products known as E6 and E7, and these are basically proteins that get created when HPV infects the cell. So the E7 protein binds a protein in our bodies known as PRB, or the retinoblastoma protein, and that leads to a deregulation of cellular proliferation as well as an overexpression of P16. So what happens is the retinoblastoma protein normally inhibits the transcription factor E2F, which synthesizes P16. But when E7 binds PRB, that inhibits its action, and so the brake on E2F is sort of lifted, and that transcription factor then causes increased synthesis of P16. So P16 ends up getting overexpressed, and it can actually act as a surrogate marker for HPV. P16 itself is a CDK inhibitor, and it's a tumor suppressor, which is encoded by the P16 Inc4A, also known as CDKN2A. And this tumor suppressor functions by stopping the cell cycle progression at the G1S checkpoint. So, long story short, the E7 protein binding to RB ends up leading to increased expression of P16, which can act as a surrogate for HPV. The other oncogene that's important to know about is E6, which binds P53, which is another very important tumor suppressor gene, often known as the guardian of the genome. And when E6 binds P53, it targets it for degradation. And because of that, normally P53 causes kind of regulation of the cell cycle, and it prevents cells from growing like crazy. But when p53 is degraded, that blocks apoptosis and leads to an overgrowth of kind of deregulated cells. So basically, HPV is bad. It leads to E6 and E7, which are oncogene products of the virus. And oncogene means a cancer-causing gene. And these proteins bind things in our DNA that normally regulate the cell cycle. And by dysregulating our cell cycle, they cause uncontrolled cell division, which is kind of the definition of cancer. So I keep saying that P16 can act as a surrogate for HPV positivity. And in terms of how we test for HPV positivity or P16 testing is done using immunohistochemistry or IHC. We're looking for a specific protein and we're looking for expression of that protein, which is P16. HPV testing is done using PCR and RNA in situ hybridization. We're basically looking for the presence of HPV DNA. So there is a guideline from the College of American Pathologists, and it was published by ASCO, and it states that you can use P16 immunohistochemistry as a surrogate for HPV positive status when there is at least 70% nuclear and cytoplasmic expression with moderate to strong intensity. So if the sample of tissue that you're looking at has moderate to strong intensity of P16 expression and there's at least 70% expression, only then can it be used as an HPV surrogate. Otherwise, if you're looking at an oropharyngeal squamous cell cancer with weak or less than 60% P16 expression on IHC, these samples should have confirmatory high-risk HPV testing. And in the NCCN guidelines, there's a note that clinical centers are actually recommended to ascertain the concordance rate of P16 and direct HPV testing because this can actually vary by region. So if you're considering using a P16 IHC alone, then sort of institutionally, you're recommended to make sure that they align. Typically, the concordance between P16 positivity and HPV positivity is very high. It's around 95% or higher. But as you can see in this image, it's really only when both P16 and HPV are positive that we see the best outcomes. If there's a discordant kind of result, then these patients still tend to behave worse and tend to have kind of closer outcomes compared to situations where both P16 and HPV are negative. I have an example here of a CT scan showing a P16 positive base of tongue oropharyngeal squamous cell cancer. I do think that head and neck cancers can be really tricky to see because anything that's involving the mucosa generally is really hard to see on a CT scan, so it really helps to administer contrast. This is an example of a CT scan from Radiopedia, and it's showing there's two arrows here. The first arrow is pointing to some nodular irregularity that we see in the right base of tongue. And then this other arrow is pointing to a large cystic right level 2 node that we see. So again, contrast-enhanced imaging, especially at the time of CT simulation, is really, really helpful to help kind of delineate both the primary as well as the lymph nodes. And PET-CT is extremely helpful as well. So it's important to fuse the PET-CT whenever possible when you're planning, because that will help you delineate your GTVs. So this brings us to the staging for oropharyngeal cancer. And remember, HPV positive versus HPV negative, also known as P16 positive versus P16 negative oropharyngeal cancers, have very different staging. So as we go through this, I'm going to kind of juxtapose P16 negative versus P16 positive and point out some of the key differences. Starting with the T staging for P16 negative on the left side of this diagram and then P16 positive on the right side of this diagram, or rather table. So the T1, 2, and 3 are fairly similar, right? T2 is less than or equal to 2 centimeters, T2 is 2 to 4 centimeters, and T3 is anything greater than 4 centimeters, or for P16 negative, anything with extension to the lingual surface of the epiglottis. Now, T4 is anything that invades adjacent structures for P16 positive. So for P16 positive, it's just T4, and it's anything that invades the larynx, extrinsic muscles of the tongue, medial pterygoid, hard palate, mandible, or beyond. For P16 negative, these tend to be more aggressive tumors, and it is actually divided into T4A versus T4B. So tumor invading the larynx, extrinsic muscles of the tongue, the medial pterygoid, the hard palate, or the mandible are considered T4A. But then if it invades the lateral pterygoid muscle, the pterygoid plates, the lateral nasopharynx, the skull base, or the carotid, it's T4B. And this is fairly similar to what we saw with oral cavity staging, where if it was encasing the skull base or the carotid, it's T4B. I usually try to remember if it's more soft tissue structures or the mandible, which is right adjacent to that mucosa, then it's T4A. So T staging for P16 negative and positive is fairly similar. Just know that P16 negative has T4A versus B, and P16 positive just calls it all T4. The clinical nodal staging is a beast for head and neck cancer. And for P16 negative, it is kind of a very complicated clinical nodal staging. But fortunately, it's the same exact clinical nodal staging that we saw for oral cavity cancer. So I'm not going to read through everything, but what I will say is that if you can memorize the P16 negative clinical nodal staging and the pathologic nodal staging for what we see for P16 negative, you will have memorized the nodal staging for most disease sites in the head and neck, including oral cavity, as well as larynx and hypopharynx. So it's good to kind of memorize this. It's really hard to do, but once you do it once, you've learned it for most of the head and neck disease sites. P16 positive, of course, has a completely different clinical nodal staging. So to be P16 negative in clinical N1, you have to have a single ipsilateral node less than or equal to 3 centimeters. If you're P16 positive, however, you can have multiple ipsilateral nodes. They just have to be ipsilaterally located, and they can be up to 6 centimeters in size. So for P16 positive, N1 is anything that's ipsilateral only and anything that's 6 centimeters or less, but you can have as many nodes as you want. For clinical N2 for P16 positive, you can have either contralateral or both ipsilateral and contralateral, so bilateral nodes, again, up to 6 centimeters in size, and that is N2. And then P16 positive clinical N3 is anything greater than 6 centimeters. So you'll see that for P16 negative, N2 and N3 are further subdivided into N2A, N2B, N2C, and then N3A and N3B. And they care about if there's any overt extranodal extension. They care about the size. With P16 positive, there's no concern about extranodal extension whatsoever. If it's ipsilateral and if it's less than or equal to 6 centimeters, you can have as many nodes as you want. You can have as much extranodal extension. However, it is still considered clinical N1. So you can already see that the staging for P16 positive versus P16 negative is much more lax, right? And things that would be classified as an N3B for P16 negative would still be a clinical N1 for P16 positive. So if there's ENE is mainly what I'm getting at. So the P16 positive clinical nodal staging is quite lax compared to the P16 negative. The pathologic nodal staging is similarly quite different and quite lax for P16 positive compared to P16 negative. Now again, I'm not going to read through every single detail of the P16 negative pathologic nodal staging because we have gone through this already for oral cavity and it's the exact same. The only thing I'll point out is that the clinical and pathologic nodal staging for P16 negative are identical except for one feature, which is that if you have a single ipsilateral node that's less than or equal to 3 centimeters with positive extranodal extension, that would be a clinical N3B, but it is a pathologic N2A. Only if it's a single ipsilateral node less than or equal to 3 centimeters in size with ENE. That would be an N3B by clinical staging, but it's an N2A by pathological staging. And that is kind of the main difference. Everything else lines up exactly with the clinical nodal staging. The pathologic nodal staging for P16 positive is completely different, and it's solely based on the number of lymph nodes involved. So if there's 4 or fewer lymph nodes involved, it's pathologic N1. If there's 5 or more lymph nodes involved, it's pathologic N2. So the clinical versus pathologic staging for P16 positive are completely different, and with the clinical nodal staging for P16 positive, we really don't care how many nodes are involved. With the pathologic nodal staging, it's N1 or N2. There's no N3 with the pathologic staging. If it's 4 or fewer nodes, it's pathologic N1. If there's 5 or more, it's pathologic N2. And then I don't have a slide on M0 versus M1, but whether it's P16 positive or negative, M1 is any distant metastases. So here's the group staging for P16 negative tumors. And you can see that 4C is limited to anything that has distant metastasis, so M1. 4B is anything that's T4B or N3 nodal status. Stage 4A is anything that's T4A or N2. And then anything that's T3 or N1 is stage 3. And stage 2 is just T2N0, stage 1 is just T1N0. So we kind of get aggressive pretty quickly, right? Anything that's T3 or N1 is automatically stage 3. Anything that's T4 or N2 or above is automatically stage 4. So quite aggressive with the group staging for P16 negative, and that is because these are more aggressive tumors. Now compare that to the group staging for P16 positive tumors, and you can see that there's a lot less dark kind of stage 4 color on here, and there's a lot more light stage 1 and stage 2 on here. That is because for P16 positive, we allow things to be more aggressive, and we still have a lower group staging for them because these have a better prognosis. So of course, it's very confusing, and there's a different group staging system for clinical versus pathologic P16 positive. So for both of these, stage 4 is anything that is M1. And even if you're T4, even if you're N2 or N3, if you're P16 positive, you are still not considered a stage 4. That's starkly different from P16 negative, right? Where if you were T4 or N2 or N3, you are automatically stage 4. However, for P16 positive, the only way you can be stage 4 is if you have distant metastasis. Otherwise, you're stage 3 or lower. So then the subtle differences between the group staging for clinical versus pathologic staging for P16 positive are a little bit tricky to memorize. So let's try to focus on what is similar. So with the clinical staging, if you are T1 to T2, N0 to 1, you're stage 1. And the same applies for the pathologic. So if you're T1 to T2 and you're N0 to 1, you're still stage 1. If you are T1 to T2 and you're N2, then you're stage 2. And same thing for both clinical and pathologic staging. So if you're T1 to T2, N0 to 1, you're stage 1. If you're T1 to T2, N2, you're stage 2. That applies for both. The only thing that's different is because we don't have that N3 designation in the pathologic staging, remember? So N3 or T4 in the clinical staging is stage 3. But if you have T3 to T4, N0 to 1, you're stage 2. If you have T3 to T4 and you're N2, then you're stage 3 in the pathologic staging. So this is very confusing, and me saying it again and again is not going to help to remember it. I think it's something you kind of have to stare at, write out, think of your own ways to learn this. But the biggest takeaway here is that with P16 negative, T4 or N2 to 3 automatically made you a stage 4. With P16 positive, whether it's clinical or pathologic staging, the only thing that makes you stage 4 is if you're metastatic. But otherwise, it's, stage 3 or lower. Now, some folks believe that the TNM and the group staging for P16 positive oropharyngeal cancers was changed a little bit prematurely. As we know, the reason that this was changed is because P16 positive tumors behave so much better. They have such an improved prognosis compared to their P16 negative counterparts, and thus the impetus for changing the staging system, including the TNM as well as the group staging, because staging is meant to reflect the prognosis of cancers, and if P16 positive patients have a better prognosis, it makes sense that we stage them accordingly. However, it's important to realize the reason some people think this was done prematurely is because our treatment paradigms really have not shifted to reflect different treatments for P16 positive based on the stage. And if you look at the NCCN guidelines, the treatment recommendations for P16 positive and negative tumors are largely the same. And if we are treating these patients off clinical trial, the standard of care really is to treat them the same for now. Now, there are efforts to try and identify subgroups of these P16 positive patients in whom we can actually de-escalate therapy. The main way that we're trying to de-escalate therapy is to decrease the dose of radiation or avoid radiation altogether. We're trying to find out how we can do that in a safe way for these P16 positive patients, but these are ongoing efforts, and these clinical trials are really ongoing, as we will talk about. There's not a standard of care right now that reflects different management paradigms for P16 positive versus negative. And the reason that some people are a little bit, I think, wary of the updated staging system is because they feel that it was done kind of prematurely. And it's important to realize that even though P16 positive tumors behave better than P16 negative tumors, they are still aggressive cancers, and they should still be treated like an aggressive head and neck cancer. Just because they're P16 positive doesn't necessarily make them indolent or less. They're still cancer, basically, is the point I'm trying to make. So I think that's an important kind of background to realize about the staging. And as we will see in our treatment paradigm, we really treat these tumors, whether they're P16 positive or negative, the same, because right now we don't have robust data for de-escalation. It's something that we are working on. So how do we manage these patients? And with oropharyngeal cancer, patients often have two different pathways that they can pursue. So one pathway is for surgery and neck dissection, followed by a tailored adjuvant approach. And patients that tend to be good candidates for surgery are patients that have smaller tumors, so T1 to T2 tumors, select T3 lesions, and also if they have a lower nodal burden, so typically N0 to N1. And for these patients, the approach is often a transoral robotic surgical approach, so TORS is the acronym for that. And that allows them to be less invasive than they would have been otherwise. And in terms of neck dissection, they need to have typically at least an ipsilateral neck dissection if it's a well-lateralized tumor. But for tumors of things like the base of tongue or the soft palate, which can actually drain, they have pretty extensive lymphatic drainage and they can go bilaterally. We really prefer a bilateral neck dissection. So again, it depends on the nodal status as well as the location of their primary tumor. And then in terms of adjuvant treatment, same principles that we talked about in our general principles talk, as well as in the oral cavity talk. Typically, adjuvant radiation to 60 gray, we consider if they have T3 to T4 tumors, if they have N2 to N3 disease, LVSI, PNI, close margins. And then for a positive margin or positive extranodal extension, then we actually think about adding concurrent chemotherapy. Typically, it's concurrent weekly cisplatin. And the radiation dose we bump up to 66 gray and 33 fractions to take care of that microscopic disease that's positive. So that is the pathway of surgery followed by neck dissection, and then a tailored adjuvant radiation and chemotherapy approach. The other pathway that these patients can pursue is one of definitive radiation. And definitive radiation is an option, again, for T1 to T2 and 0 to 1 tumors. And if they have more aggressive tumors that may be too aggressive for surgery, where the surgeon does not think that they can get a good clean margin, if they are concerned about the burden of disease, Then, for things like T3 to T4 tumors, N2 to N3 with a very large nodal burden or significant extracapsular extension that you can clearly see on a scan, then we recommend definitive radiation. And the dose is typically 70 gray and 35 fractions to the primary tumor and involved nodes. You can do a sequential boost approach with 50, 60, 70 gray, all given at 2 gray per fraction. You can do a simultaneous integrated boost, something like 56, 63, 70 gray, all given in 35 fractions. So there are options. And we typically will add concurrent chemotherapy if they have stage 3 to 4 disease. So if they have significant node positivity or if they have T3 to T4 disease, we typically add concurrent chemotherapy. And then the dose, as we've talked about in general principles, is typically cisplatin 40 milligram per meter squared weekly. A lot of the studies used 100 milligram per meter squared given every 3 weeks, but we do have kind of retrospective data suggesting that cisplatin 40 milligram per meter squared weekly is equivalent in oncologic outcome and also improved in terms of toxicity. And then, of course, if patients have a contraindication to cisplatin, such as poor renal function or concerns about ototoxicity, then we can substitute a different agent, so something like carboplatin 5-FU or cetuximab or carbotaxol. So there are options for patients that aren't good candidates for cisplatin. So in a nutshell, that is the management of oropharyngeal cancer. And with oral cavity, remember we said that whenever possible, we try to treat these patients with upfront surgery. With oropharyngeal cancer, really both paradigms are options. And so for earlier stage patients that might be candidates for surgery, it's kind of a risk-benefits discussion, and oftentimes it's driven by patient preference. In other situations where the surgeon can clearly tell by the scan that they're not going to be able to get a clear margin, or if there's overt ENE on the scan, then we often prefer going the definitive chemoradiation route, just because then we can spare patients from trimodality. So historically, radiation actually was the standard of care for oropharyngeal squamous cell cancers because surgery was historically very invasive and very morbid with an open surgical approach. With the advent of TORS, which is transoral robotic surgery, obviously the techniques have improved a lot, and now the procedures can be performed less invasively with the robotic approach. And because of that, TORS has kind of led to a resurgence of surgery in the management of oropharyngeal squamous cell cancer. And so now it's nice that patients have this option as well. The goal with surgery, as always, is to try and obtain clear resection margin, so about 2 millimeters ideally at least, and also to maintain good functional outcomes. And like I said earlier, if the surgeon looks at the imaging and does not feel like those two outcomes are achievable, then they typically will recommend that the patient go for either radiation or chemoradiation, whichever is appropriate in the situation. And that is why it's so important to see these patients in a multidisciplinary setting, have multidisciplinary tumor board, so you can kind of hear the input from the surgeon as well, and together make a decision as the cancer team. In terms of, so we kind of talked about the primary, right? We try to obtain clear margins, maintain good functional outcomes. And in terms of the neck dissection, I would say that has kind of lessened in intensity as well. Radical neck dissection involved removing levels 1B through 5 and sacrificing several structures, including internal and external jugular veins, sternocleidomastoid, omohyoid, cranial nerve 11, and the submandibular glands. The modified radical mastectomy is the same, but trying to leave one or more of the jugular veins, SCM, omohyoid, or cranial nerve 11 intact. And then the selective neck dissection is really a modified radical approach, but we might not fully dissect levels 1B through 5. What I have seen at my institution most commonly for oropharyngeal cancers and generally head and neck cancers, kind of all of them, is a selective neck dissection approach, kind of tailoring which levels we go after based on what we know about the patterns of nodal spread. So for oropharyngeal squamous cell cancers, we at least need to dissect levels 2 through 4 ipsilaterally. If the tumor is invading a midline structure or involving a midline structure, such as the base of tongue or the soft palate, then we need to go after bilateral levels 2 through 4. And then, of course, if we can see on a scan that a particular level is involved, such as say 1B is involved, then we go after 1B as well. So a selective neck dissection is typically what I have seen used most commonly. We've talked extensively about the radiation dose, elective nodal coverage in our general principles lecture, so I don't want to spend a ton of time on that here. I will point out there's a phase 1 to 2 trial called RTOG 0022 that looked at an alternate fractionation scheme. So instead of doing 2 gray per fraction, they looked at 2.2 gray per fraction, so 66 gray and 30 fractions to the primary, specifically for T1 to 2 and 0 to 1 tumors. So that is an alternate fractionation scheme that exists. In terms of elective nodal volume, for oropharyngeal squamous cell cancers, we at least cover levels 2 through 4 and the retropharyngeal nodes. So anything with pharynx in the name, you definitely want to think about covering the retropharyngeal nodes. And then typically, if an adjacent level is involved, so if level 2 is involved, for example, we cover the adjacent level, so 1B as well as 5. And if there's a well-lateralized tonsillar tumor with minimal invasion into the soft palate or the base of tongue, then we can sometimes consider kind of ipsilateral lymph node coverage. But anytime there's invasion of a midline structure, I err on the side of bilateral coverage because once it invades into the soft palate or the base of tongue, we know that those organs can drain bilaterally. So I tend to err on the side of bilateral coverage there. But a well-lateralized lateral tonsil tumor, you can consider ipsilateral lymph node coverage, presuming that they don't have contralateral lymphadenopathy. If they do have contralateral lymphadenopathy, that's a different story. And again, same principles apply for elective nodal coverage for post-op radiation as well. So I'll kind of leave this here for your reference. In the last portion of this talk, then, I would like to get into some of the evidence and talk about some data that's sort of specific to the oropharyngeal cancer world, starting with some evidence comparing surgery to radiation for oropharyngeal squamous cell cancers. As we said earlier, in the modern era, with the existence of TORs, both surgery and radiation are options for managing typically earlier stage oropharyngeal squamous cell cancers that are amenable for surgery. And when patients are making a decision between radiation and surgery, it's important for us to counsel them on what to expect, and with that informed kind of background, then they can make an informed decision. So ORATOR is a trial that actually randomized patients with early stage oropharyngeal squamous cell cancer to TORs plus neck dissection and then tailored adjuvant treatment based on their pathology versus definitive radiation to a dose of 70 gray. It was a relatively small randomized study. It only had 68 patients on the study. And these patients had to have T1 to T2 tumors. They had to be N0 to 2, and the tumors had to be 4 centimeters or smaller. And like I said, they were randomized to surgery and neck dissection versus definitive radiation, and they did get concurrent chemotherapy if they had node-positive disease. The primary endpoint of the study was something called the MDADI score. So MDADI stands for the MD Anderson Dysphagia Index, and they measured their dysphagia score at 1 year. So MDADI is meant to kind of measure the level of dysphagia, right? And it has a global, emotional, as well as physical subscale, and scores tend to range from 20 being the worst to 100 being the best. So at 1 year, the mean MDADI score was 86.9 in the radiation arm versus 80.1 in the surgery arm, and that was statistically significant. So 87-ish versus 80-ish, favoring radiation. They found that in terms of side effects, there were higher rates of neutropenia, hearing loss, and tinnitus with radiation versus higher rates of trismus with TORs. And then at longer-term follow-up, so 2 to 3 years, radiation continued to show improved swallowing function, but the differences were of smaller magnitude with longer-term follow-up. They found higher rates of dry mouth sores related to the radiation versus higher rates of using nutritional supplements with TORs. So ORATOR technically demonstrates that radiation is superior to TORS in terms of swallowing function. And I know that we as radiation oncologists, really kind of are a proponent of radiation because of this data. But again, I think that there can be some debate over the clinical significance of how superior radiation is. And that's where you get into the debate of statistical significance versus clinical significance. But I think that this study is nice because it gives us an idea of the types of side effects that patients can expect in the long term, comparing the two different modalities. And I think it does help us to kind of counsel patients as well in terms of what to expect as they're looking to get one of these therapies. Again, as we counsel, a huge factor to consider is risk factors and whether or not we think that they would need adjuvant radiation on the back end. And if that's the case, then that kind of changes things a little bit too. Now, there's another trial that I don't have a slide on, which is ORATOR 2. This was a de-escalation trial that compared 60 gray of radiation with cisplatin versus transoral surgery with de-escalated adjuvant radiation. But it actually closed early due to unacceptable rates of hemorrhage and death in the surgery arm. So I'm not going to get into ORATOR 2 here, but just be aware that that trial exists too. But unfortunately, it ended up not being very helpful because of those outcomes. The rest of the time, I'd like to focus on the evidence for HPV status and improved prognosis in HPV patients, and then get into some of the studies that are trying to de-escalate therapy for HPV-positive patients. RTOG 0129 was a study that we actually talked about in our general principles lecture. And we briefly mentioned this trial because it compared standard fractionation, 70 gray and 35 fractions over 7 weeks, compared to accelerated fraction of 72 gray and 42 fractions delivered over 6 weeks. And in the trial, they gave concurrent cisplatin. And as we know from our general principles talk, typically when we give concurrent chemotherapy, the benefits of accelerated fractionation or hyperfractionation typically go away. And standard fractionation is the same as accelerated fractionation or hyperfractionation in the setting of concurrent chemotherapy. So just like we have learned, RTOG 0129 kind of mirrored or paralleled what we already know, and it showed that there was no significant difference in any of the outcomes between the two different radiation regimens because, again, they were giving concurrent cisplatin. So from that standpoint, it was negative. However, from the patients that were treated on RTOG 0129, they performed a retrospective analysis of overall survival and HPV status in these patients. And what they found is that patients that had either HPV-positive disease or P16-positive disease had significantly improved overall survival and progression-free survival. So the 3-year overall survival was about 82 to 84% in the HPV-positive / P16-positive cohort versus 57 to 51% in the HPV-negative / P16-negative cohort. The 3-year progression-free survival was 74% in the HPV-positive / P16-positive cohort, compared to around 40% in the HPV and P16-negative patients. So in this study, they showed that HPV and P16 status actually had really good agreement with a kappa score of 0.8. And you can see in the outcomes that their outcomes were very, very similar, right? 80s versus 50s for overall survival, 70s versus 40s for progression-free survival. And this study really showed that there was significantly improved survival and progression-free survival in HPV-positive patients. Also showed that really good correlation between HPV status and P16 status. They then went on to kind of divide the patients into 3 different risk groups and created a nomogram based on the P16 status, the number of pack years, as well as the stage. So in this study, low-risk patients were P16 positive with less than 10 pack year smoking history, or P16 positive with greater than 10 pack years but N0 to N2A disease. Intermediate risk patients were P16 positive with greater than 10 pack years and N2A to N3B disease, or P16 negative with less than 10 pack years and N2 beta N3 disease. And then finally, high-risk patients were P16 negative with greater than 10 pack years or P16 negative with less than 10 pack years and T4 disease. So the important takeaways from this nomogram are that P16 positive patients tend to do better, and patients with fewer pack years, specifically less than 10 pack years of smoking history, tend to do better. Also, T-stage and N-stage matter as well, and they are used to kind of help risk stratify. So this nomogram utilized three things, which were the P16 status, the number of pack years, as well as the stage. And as you can see in the Kaplan-Meier curve, they created these low, intermediate, and high-risk groups, which are kind of a useful nomogram to help predict these patients' overall survival. So RTOG 0129, among other studies, really highlighted that patients that have P16 positive oropharyngeal cancer have significantly better outcomes. And this was very exciting because it led to the question, well, if they do so much better, then do we need to treat them as aggressively? Can we actually de-escalate treatment based on their HPV status? Now, unfortunately, as I alluded to earlier, to date, there has not been really compelling evidence that yes, we can. There has definitely been signal from phase 2 trials, but none of that has really come to fruition. And to date, if managed off clinical trial, HPV positive versus negative patients are really managed very similarly. So we'll go through these trials, but there were some negative studies for de-escalation of chemotherapy. Recently at ASTRO, HN005 was presented, and this looked at de-escalation of the radiation dose in the definitive setting, and that was a negative study. And now there are some ongoing trials to kind of de-escalate in the post-operative setting, but we're sort of waiting for them to come to light. But this was obviously it's very exciting to think that we don't need to be taking these patients all the way to 70 gray. But unfortunately, to date, we don't have data that suggests that we actually can de-escalate. We need to get better at identifying specifically which patients are candidates for de-escalation. But right now, the treatment paradigm for HPV positive versus negative is largely the same. So we can start by looking at the first sort of wave of negative studies for de-escalation. And these are studies that we did briefly mention in our general principles talk as well. RTOG 1016 and the de-escalate HPV trial. So both of these trials tried to replace concurrent cisplatin with radiation, which we know to be quite toxic at times, with cetuximab, which is an EGFR inhibitor, with the idea that cetuximab might be easier on patients, might be less toxic. And both of these trials enrolled HPV positive patients. RTOG 1016 enrolled T1 to T2, N2A to N3, or T3 to T4, N0 to 3. De-escalate enrolled HPV positive patients that were low risk with less than 10 years of pack year smoking history. So they randomized patients to radiation with cetuximab versus radiation with cisplatin, which was the standard of care. And the radiation was delivered a little bit differently. So 1016 actually had kind of accelerated radiation. So 70 gray and 35 fractions delivered 6 fractions per week over 6 weeks, whereas de-escalate delivered it at 5 fractions per week over 7 weeks. But both of the trials did not show any benefit to the cetuximab. So RTOG 1016 actually showed worse outcomes with cetuximab. The overall survival was about 7% worse, 78% versus 85%. The progression-free survival was about 9% worse, 67% versus 78%. And they found similar toxicity between arms, so it's not like cetuximab helped improve toxicity. Same kind of results in de-escalate as well. So the primary outcome was grade 3 to 5 toxicity, and cetuximab did not show any significant improvement in toxicity. It was just around 30% in both arms. And the overall survival was also significantly worse with cetuximab, about 10% worse. And the recurrence risk was also worse with cetuximab. It was doubled, so 6% versus 3%. So both of these trials, RTOG 1016 and de-escalate, were negative, And not only did they show very similar toxicity between arms, kind of getting rid of this idea that cetuximab is somehow less toxic, they actually showed worse oncologic outcomes, including overall survival and progression-free survival with concurrent cetuximab. So therefore, we do prefer cisplatin whenever possible, and cetuximab is really reserved as an option for patients that would not be candidates for cisplatin. So we can't de-escalate the systemic therapy. Can we de-escalate the radiation dose? There was a phase 2 trial, NRG HN002, that showed some promise. Now, this trial enrolled patients with oropharyngeal squamous cell cancer and 10 pack years of smoking or less, and they randomized them to either IMRT plus cisplatin or IMRT alone. And the radiation that they gave for both arms was a decreased dose compared to our standard radiation, which is 70 gray. Both arms got 60 gray of IMRT. So in the concurrent cisplatin, they got 5 fractions per week over a total of 6 weeks. In the IMRT alone, they got 6 fractions per week, so they kind of had accelerated treatment over 5 weeks. In both arms, they treated 54 gray to an intermediate risk volume and 48 gray to the low risk volumes. But the key thing to realize is that both arms on this study were using a decreased dose of radiation than what we would standardly give. Now, to qualify for a phase 3 study, each arm had to achieve a 2-year PFS of greater than 85%, which was chosen based on a historical control, as well as a 1-year MDADI score of 60 or higher. Both arms met the MDADI score requirement. However, the IMRT plus chemotherapy arm was the only arm that rejected the null of meeting that greater than 85% PFS threshold. It had a PFS of 91%. The IMRT alone arm had a PFS of 88%, and it was not statistically significantly improved from the historical control. And so therefore, the IMRT plus cisplatin arm met both of the pre-specified endpoints, and this justified advancement of that arm onto a phase 3 study. That brings us to HN005, which was originally designed as a phase 2/3 trial, but because the phase 2 portion was negative, unfortunately, it will not be proceeding to a phase 3 trial. But this was trying to study de-escalation in a phase 3 setting. So this study recruited patients with P16 positive stage T1 to T2 N1 or T3 N0 to N1 tumors, and they had to have less than 10 pack year smoking history, and they randomized them to one of 3 arms. So their control arm was the winning arm from RTOG 1016, which was radiation to 70 gray given over 6 weeks, so 6 fractions per week, with concurrent cisplatin. And then their 2 experimental arms were 60 gray over 6 weeks with concurrent cisplatin, or 60 gray over 5 weeks with concurrent nivolumab. So in that nivolumab arm, they were getting 6 fractions of radiation per week. And then in the 60 gray with cisplatin arm, they were just getting 5 fractions of radiation per week. Unfortunately, both of the experimental arms failed to meet the pre-specified endpoints for non-inferiority, and so they were not selected to proceed to a phase 3 trial. So if you take a look at the progression-free survival, 98% in the first arm, so the control arm, versus 89% with 60 gray and cisplatin, and 90% with 60 gray and nivolumab. So you can see a 10% improvement in the progression-free survival with the control arm. The overall survival looked fairly similar, 99% versus 98% versus 96%, but that progression-free survival difference is quite large. It's about 10% between the experimental arms and between the control arm. So this was highly disappointing because we were really hoping that for these kind of favorable risk HPV-positive cancers, we could de-escalate our radiation therapy from 70 gray down to 60 gray. But with NRG HN005 being negative, at this point, that's not something that we can do. Now, It's possible that this trial was just too broad, and maybe there is a more select subgroup of patients where de-escalation is still an option. But before we can identify those patients, we really need to find a way to better risk stratify these patients and identify those patients that might be amenable for de-escalation. So I don't know what that is, if that's a genomic marker or something else. But this is, like I said, an ongoing area of study, but not something to date that has been brought to fruition. So now we have two kind of avenues that are busts, right? We can't de-escalate the chemotherapy we found. We also can't de-escalate the dose in the definitive setting. So that brings us to the question, can we de-escalate in the post-operative setting? Can we utilize TORS to our advantage? And then for patients that are status post-surgery, maybe adjuvantly we can think about ways to de-escalate. So there are a few different trials. So one of them is the ADEPT trial. It's a phase 3 study looking at HPV-positive cancers that have extranodal extension. And it's asking if we can maybe de-escalate by getting rid of the concurrent cisplatin in the postoperative setting. So for these HPV-positive cancers with extranodal extension on pathology, they're randomizing them to postoperative radiation to 60 gray with or without concurrent cisplatin, and that is an ongoing trial known as ADEPT. There is ECOG 3311, which is a phase 2 trial that actually was published and we will go over. But it's looking at HPV-positive T1 to T2 cancers and treating them with a risk-adapted approach. So if they are low risk, they don't get any adjuvant therapy. If they're medium risk, they get 50 gray versus 60 gray adjuvant radiation, so they're randomized. And then if they're high risk, they get 66 gray with concurrent cisplatin, which is still the standard of care. And this trial was actually promising because it was a phase 2 trial and showed that all of their arms satisfied their pre-specified endpoint, which was having a confidence interval, the lower limit of their confidence interval over 85%. That was kind of a very wordy and long-winded way of saying that this trial was a positive trial and it showed excellent outcomes with their risk stratified approach. So we'll talk about that more in detail here in a second. The final trial is the PATHOS trial, which is a phase 3 trial looking at HPV-positive cancers and also very similarly randomizing them to kind of a risk-adapted postoperative approach. So if they're low risk, they don't get any adjuvant therapy. If they're medium risk, they get 50 versus 60 gray of radiation. And if they're high risk, they get 60 gray with or without concurrent cisplatin. So far, they just have a secondary analysis published comparing two different surgical styles, so TORS versus transoral laser microsurgery. And they found less impaired functional outcomes 4 weeks after the laser microsurgery. But we're still awaiting kind of their primary endpoints here. So this is just an overview of some of the ongoing and recently published studies. The ECOG E3311 trial was published, so I just want to take a few moments to get into the details of that. So this was a phase 2 study of patients with HPV-positive T1 to T2 oropharyngeal squamous cell cancer. And after undergoing TORS, they stratified these patients into low, medium, and high risk. So low risk were T1 to T2 patients with greater than 3 millimeter clear margins, and they had to have PN1 to N2 disease with no extranodal extension. The medium risk patients were PT1 to T2 with less than 3 millimeters margin, or they had focal extranodal extension defined as less than or equal to 1 millimeters of ENE, or they had up to 4 lymph nodes. And then the high-risk patients had either positive margins or greater than 1 millimeter of ENE, or they had 5 or more nodes, so they were N2, pathologic N2 for HPV-positive staging. So low, medium, and high risk. The low-risk patients were just observed. The medium-risk patients were randomized to 50 gray of postoperative radiation or 60 gray of postoperative radiation. And then the high-risk patients were treated with 66 gray of postoperative radiation with concurrent weekly cisplatin. And their 2-year progression-free survival, they wanted to exceed a lower limit of 85% on their confidence interval, and they met that pre-specified endpoint across all of the arms. And you can see that for the low and medium risk patients, their PFS was 95 to 97%. For the high risk patients, it was a little bit lower, but it was still above 85% on that lower limit of the confidence interval. It was 91%. So this trial is a promising trial for kind of de-escalation in the post-operative setting. And the group that was really being de-escalated was that medium risk group where they were getting 50 gray instead of 60 gray post-operative radiation. At my institution, we are currently enrolling patients on a phase 2 study that's sort of similar to ECOG E311, using very similar criteria to risk stratify patients after TORS into low versus intermediate versus high risk. The only difference is that in the intermediate risk arm, the dose is even lower, 30 gray and 15 fractions. And in the high risk arm, the dose is lower as well, so it's 50 gray and 25 fractions with concurrent cisplatin. So this is an ongoing study and definitely will be very interesting to see the results. That was a lot of data there at the end. So just to summarize some of the big takeaways here, we saw from that secondary analysis of RTOG 0129 that P16 positive patients really have an improved prognosis, significantly improved overall survival and progression-free survival compared to their P16 negative counterparts. And so this led to the question, can we de-escalate therapy for these patients? Do we need to be as aggressive as we are with our P16 negative patients? And what I presented initially was kind of a series of negative trials for de-escalation efforts, right? They tried de-escalating from concurrent cisplatin to cetuximab, but RTOG 1016 and the de-escalate trial both sort of showed that not only was cetuximab the same in terms of toxicity, it was worse in terms of overall survival and progression-free survival. So that answer was a no. And then HN002 seemed promising because their progression-free survival was better than the historical control when they looked at the 60 gray plus cisplatin arm. But then HN005 was a phase 2 to 3 trial, and when 60 gray with concurrent cisplatin was compared with 70 gray with concurrent cisplatin, it was significantly worse. And then there are ongoing efforts now to try and de-escalate in the adjuvant setting. So for patients that are getting TORS, can we maybe lessen the amount of radiation that we're giving post-operatively? And so far, ECOG E3311 is the phase 2 trial that we have in that space, and it shows some promise. But just to reiterate, for now, HPV positive and negative off trial are pretty much treated the same. And we are still waiting for this data to develop. And I do think that we need to kind of better identify the specific patients. I think there probably is room for de-escalation, but we probably need to better identify the lower risk group of patients that are candidates for de-escalation. So what I have been taught by my mentors is that HPV positive oropharyngeal cancer has better prognosis, but it is still cancer and it still needs to be taken very seriously. And so even the data is telling us that we can't de-escalate so aggressively. So an exciting space, but I think for now, still definitely developing. So that brings us to an end. Thank you so much for bearing with me. I know this was a long one, but oropharyngeal cancer is definitely the most common cancer that you'll see in terms of head and neck cancers. So it's definitely an important one to be very familiar with and understand. And I hope that this was helpful in getting you there. Thank you so much for your time and attention.